So today's journal club, the topic for today's journal club is the diagnostic ability of macular ganglion to diagnose pre-perimetric glaucoma. So we'll just go into the introduction of glaucoma, an overview of what glaucoma is. So glaucoma is a group of eye disorders which is characterized by optic neuropathy, optic nerve changes, visual field defect, and is the most common cause of irreversible blindness. It's estimated at 60.5 million patients globally. So classification of glaucoma, it can be classified into primary glaucoma, childhood glaucoma, and secondary glaucoma. Under primary glaucoma, we have open angle glaucoma, angle closure glaucoma, and then under childhood glaucoma, we have primary congenital glaucoma, juvenile glaucoma, as well as secondary exfoliation glaucoma, steroid-induced glaucoma, photolytic glaucoma, and so on. And so risk factors that predispose the patient to glaucoma. Of note is the age, which has to be greater than 40. Then ethnicity, it usually occurs in Africans and history. Then there's also a patient who also present with raised IOP. Then the other risk factors are a thin cornea, myopic patients, and also those patients that have comorbidities like diabetes and high blood pressure. We'll just now define what pre-perimetric glaucoma is. Pre-perimetric glaucoma is characterized by glaucomatous optic nerve, damage to the retinal nerve fiber layer without the visual field defects. So pathology of glaucoma, we know that glaucoma is a degenerative progressive disease. So what usually happens is that there will be death of the retinal ganglion cells, and this will lead to detectable morphological changes in the optic nerve head, and also there will be thinning of the retinal nerve fiber layer. At this stage, we can say that this is the stage where pre-perimetric glaucoma is at. Then as the disease progresses, there will be visual field defect plus the other optic nerve and retinal nerve fiber layer changes. So for diagnosis and monitoring of glaucoma, we can use functional analysis as well as structural analysis. Under functional analysis, we have the standard automated perimetry. For detecting, for standard automated perimetry, we cannot really use it to detect pre-perimetric glaucoma because we only use it when about 50% of the retinal ganglion cells are lost. That's when it can be used. Then we also have the short wavelength automated perimetry. We also have the high pass resolution, the motion detection perimetry. Then under structural analysis, we have the ophthalmoscope and also photography. For this one, we can use OCT. So the main focus for today is OCT.
Yeah, Bridget, so at this point, I'll just want to tell you, just go back to the previous slide.
Yes.
So there is only single test available to detect the optic nerve head function, and that is that visual perimetry. There is no other test that can test the function of the optic nerve. Anatomically, you can do fundus evaluation, you can do OCT, you can do HRT, everything. But to see whether your optic nerve is properly functioning or not, there is only one test, and that is visual perimetry. That is the Humphreys visual field. Okay.
All right.
Yeah, the SAP, SWAP, FDT, and all are different protocols in the visual field analysis, Humphreys visual field analysis. Right. Go ahead.
All right. Thank you. So now we'll look at what OCT is. So OCT uses a reflected light to create high resolution, cross-sectional and three-dimensional issues and materials. So we just go into history of where OCT is coming from. So initially, OCT was introduced using the time domain OCT, which was the first generation of OCT. Then in the late 1990s, a second generation was introduced, which is the septal domain OCT. So the septal domain OCT has a higher sensitivity as well as speed. Then currently, the most advanced technique that is on the market is the swept source OCT.
So what actually changed from time domain to swept source? What is the change that has happened?
Pardon?
What has actually changed from the time domain to spectral domain to swept source, first to the third generation? What actually has changed in the OCT?
So there's higher speed as well as sensitivity.
Yeah, the term that we use is called as resolution. It has become more clearer. You see the first one, the time domain image, the layers of the retina, the green which is above the orange, the layers of the retina are not very clear. Whereas in the third generation, even though it is black and white picture, you can see multiple layers which are clearly seen. Okay, so it's the resolution to differentiate each layer of the retina has improved. It's like your Apple iPhone, right? From second to third, now 11, iPhone 11 has come. So it's like that every now and then it just keeps improving. Right. Go ahead.
So these are some of the popularly used models in Zambia. We have the Zeiss Cyrus OCT. Then we also have the Topcon OCT, which we have at our hospital. Then we also have the Optoview OCT. So optic coherence tomography provides objective and quantitative structural examination of the optic nerve. It can be used for screening, as we know that in glaucoma, most patients will present asymptomatic. So we can use the OCT to screen. It can also be used for detection and also for monitoring the progression of glaucoma. Then the most assessed structures when using OCT are the retinal nerve fiber layer, the optic nerve head, the macular ganglion, and the macular ganglion cell. So this slide is just showing us the parameters that are used on OCT and also what they measure. So for the optic nerve head, we measure the vertical thickness of the retinal ring, the overall area of the ring, as well as the vertical CD. For the retinal nerve fiber layer, we measure the retinal nerve fiber layer thickness in the inferior temporal zone, as well as in the inferior quadrant. Then we can also measure the average retinal nerve fiber thickness. For the macular ganglion cell complex, it shows changes in the mean minimum thickness and the inferior temporal thickness. So the macular ganglion cell can only be analyzed using the septal OCT.
Yeah, that is the third generation OCT, the spectral domain. Yes.
Okay, so this is just optic disc analysis, sorry. So here it's showing us the mean retinal nerve fiber thickness, then here it's showing us the parameters that are measured on the optic nerve. Then for the retinal nerve fiber layer, we measure the thickness in the lower quadrant and also the thickness in the lower temporal zone.
So just 1 minute, hold on here. Mumbi, can I share my screen?
Yes, Mahesh, but Bridget,
Yeah,
you
that
need
will
to stop sharing.
yeah, that's okay. That's okay.
Bridget,
Pardon?
you can stop
Yes.
sharing so Mahesh can share.
So what I was trying to tell you is like, can you see my screen now?
Yes,
Can you
Mahesh,
all
we can
see my
Yes,
see it.
yes.
screen?
Yes, we can see it.
Okay. So the ganglion cell complex, that is the GCC, consists of the GCL, that is the ganglion cell layer, and the IPL, that is the inner plexiform layer. So these are the most important layers that gets affected earliest in glaucoma. Okay. So that is the GCC, that is ganglion cell complex, that consists of NFL, that is the nerve fiber layer, the GCL, that is the ganglion cell layer, and the IPL, that is the inner plexiform layer. Is that fine? And what I want you people to understand is this is the OCT RNFL analysis output. Okay. So what Bridget showed, that was the full printout, in which the top half talks about the optic nerve head as such, and the second half, the lower half, talks about the retinal nerve fiber layer, that is the RNFL. So if you can see my pointer, so I'll show you, this is the green layer, which is supposed to be the normal. Then you have the yellow one, which is the borderline, and then you have the red. This shows the thickness values. And below you see this temporal, superior, nasal, inferior, and again temporal. Okay. So if you look at this OCT printout of this patient, this part of the image is in the red zone, that is the temporal zone. Okay. And that is shown here as the temporal red zone. Can you understand that?
Yes, we can hear you.
Yes,
You can
yes.
go ahead.
Yes, yes. Similarly, in the left eye, if you see that the superior temporal, all the zones are in the green zone. See, the black line is the patient's measurement, and the green, yellow, and red are the normative database that is already there in the machine. The black line is for the patient. So if you look at the left eye, the black line comes in the yellow area. That means it is in the borderline in the nasal zone. So that means the nasal quadrant is in the yellow. That is, its borderline thinning is seen. And again, this right eye and left eye is shown as one is 4 quadrant: inferior, superior, nasal, and temporal. Similarly, here also inferior, superior, nasal, and temporal. But if you look at the same thing, again it is divided into 12 clock hours also. This is called as clock hour map, and this is called as quadrant map. So what happens in quadrant map is 3 clock hours get added and they become average. So that is why if you see this temporal quadrant, this is totally showing green. So if you look at the temporal quadrant and say that, okay, things are all fine, you will be missing this yellow thinning. This is not manifested here in this because 92 plus 38 plus 54, all these three got added, and when the average was taken, it looked like normal in the quadrant values. So even though you might be having some amount of thinning in the clock hour, each clock hour values, when it gets added, it might come as a normal average and you might still see a green value. Right. This is what I wanted you to understand as of now. So I can stop sharing now. Bridget can start sharing.
Okay, thank you for that, Dr. Manish.
Yeah.
Mm. So I think for this slide is actually telling us what Dr. Mahesh has explained. And this slide is also just telling us what he has explained as well, as we can see. So this is the end of my introduction. Then we'll go into the article now. So my article is taken, today's article is taken from the Biomedical Central Journal, and the title for today's article is Diagnostic Ability of Macular Ganglion Cell Asymmetry in Pre-perimetric Glaucoma. So this article was published on the 8th of January 2019 with an impact factor of 1.6, and it was ranking at 22. So the study objective was to evaluate the diagnostic ability of macular ganglion cell asymmetry to diagnose pre-perimetric glaucoma using the CIRAS Central Domain Optic Coherence Tomography. So the study was done in Taiwan at Taipei Veteran General Hospital, and the study period was from June 2014 to December 2015. The study type, we can say that this was a prospective study with a comparison. It included the subjects as well as controls. So for the subjects, these were patients who presented to the outpatient department with pre-perimetric glaucoma. So these were 67 patients. And for the controls, these were health volunteers from the same hospital who were also 67. So 67 eyes of 67 patients. So for the methodology, this study was done in 2 steps. First, there was an ophthalmic examination of participants. Then there was image evaluation by experts. So all the subjects underwent a comprehensive ophthalmic examination. This is where they checked the best corrected visual acuity, the automated refraction. They checked the IOP using the Goldman tonometer. Then they also examined the patients on slit lamp. They did a dilated fundus exam. They also did the automated visual field examination. Patients that had presented with who had eyes with a focal or diffuse retinal corresponding to glaucomatous optic disc changes with a normal visual field were assigned to the PPG group. So for the inclusion criteria for the PPG group, the age was greater than 20 years. Then the best corrected visual acuity was 612. Then the subject needed to have an open angle on gonioscopy. Yes. Then astigmatism of less than or equal to 3 diopters. Then for the inclusion criteria for the controls, they needed to have a normal anterior segment on slit lamp, and then on fundoscopy, they needed to have an optic nerve head with no glaucomatous changes, then also a normal visual field. So there was also an exclusion criteria where all the eyes that had retinal or neurological diseases were excluded, the eyes that had ocular inflammation, the eyes that had prior ocular surgery within 3 months, eyes that had prior refractive surgery were all excluded, and also the eyes that had concomitant diseases that could interfere with IOP measurements were excluded. So after that, they did the red-free photos using the CIRAS HD OCT. So for the optic disc, they used the optic disc cube of 200 by 200, and then they measured the average CD, the vertical CD, the curve volume, as well as the circumpapillary retinal nerve fiber layer thickness in the quadrants and theta quadrant. Then for the macula, they also use the 200 by 200 protocol, which they use to calculate the average, minimum, and also the regional ganglion cell inner place from layer thickness in the 6 wedge-shaped sectors. I think Dr. Mahesh explained all this. Then they also did the hemispherical comparison, as we saw from Dr. Mahesh's explanation. Then all these images were
Bridget, just go back to the previous slide. Bridget, just go back to the previous slide.
This one?
Yeah. So this output is the different output from the two other things that I had told. So this is the output of the macular complex, the GCC macular complex. So it will not give you 12 clock hours. It will have only three parafoveal superior and 3 parafoveal inferior. The central white is the fovea, and the superior 3 regions are the superotemporal, superior, and superonasal. That is the 3 parafoveal regions. And inferiorly, similarly, inferotemporal, inferior, and inferonasal, 3 parafoveal regions. And they will average all the superior 79, 85, and 89 and take a superior value and compare it with inferior value. Also, they will compare with superotemporal and inferotemporal. 79 and 71 will be compared. 85 and 78 will be compared. And 89 and 88 will be compared. So they do a hemispherical comparison, that is between the superior and the inferior. And they also do a sectoral comparison between the superotemporal, inferotemporal, supronasal, inferonasal. Yeah, that's all. Go ahead.
Thank you for that. So as I was saying, the images were evaluated by 3 glaucoma specialists who were masked of the results of the subject's clinical evaluation. So there was also an exclusion criteria of the images that had the signal strength of less than 7 were excluded. Those who had motion artifacts, poor centration, segmentation error, and artifacts used which were caused by ocular pathology, and also those that had missing data on peripapillary region were excluded. So for data analysis, they used the SPSS version 12 and the Stata version 12 software. Then they also did some statistical tests, such as the Shapiro test, the Mann-Whitney U test, and the chi-square test. Then the final results were expressed as the area under the curve. Then your specificity and sensitivity was analyzed at 90% as well as 95%. So now we'll go into the results. Table 1 shows us the demographic and the clinical characteristics of the study population. As we can see, there was no significant difference between the normal and the PPG, but there was a significant difference the PPG group showed a greater eye opening compared to the normal. Then table 2 is showing us a comparison of the circumpapillary retinal nerve fiber layer thickness, the ganglion cell inner place from layer thickness, the asymmetrical measurements, as well as the optic nerve head parameters. So we can see that for the circumpapillary retinal nerve fiber layer thickness and the ganglion cell inner place from layer thickness, the PPG group had significant lower values compared to the normal, with an exception of the nasal quadrant. Then for the ganglion cell inner place from layer absolute difference, we can see that the PPG group had a significant greater values compared to the normal. For the ganglion cell inner plexiform layer asymmetric ratio, we can see that there was no significant difference between the two groups, but there was an exception of the inferior-superior ratio, which was a difference. For the ganglion cell inner plexiform layer asymmetric
No,
index.
can you just go back to the previous 2 slides? The previous slide?
This one?
The previous one. Right. So if you see the normal and the pre-perimetric, sorry, I think that was a miscommunication. That's fine. So between the normal and the pre-perimetric group, if you see, the average value was 96 microns thickness, whereas the pre-perimetric was 86. That means the pre-perimetric glaucoma people had a thinning of the retinal nerve fiber layer, okay, which was not seen in the visual field test. That's why they are called as pre-perimetric glaucoma. Only thing, the nasal was not seen. Otherwise, the inferior was 119 in the normal group, whereas it was thin in the pre-perimetric, that is 105. This table is part 1 is understood. Similarly, if you see the GC-IPL thickness, that means GC-IPL is the ganglion cell inner plexiform layer thickness. In pre-perimetric glaucoma, even before the optic nerve head and the retinal nerve fiber layer, RNFL shows differences. The macular ganglion cell complex gets affected early. That is why if you see all the values in the normal is thicker than the pre-perimetric glaucoma group. If you see the average value of the normal group, it is 80.6, almost 81, whereas in the pre-perimetric glaucoma, it is only 76.2. That means the ganglion cell complex in the pre-perimetric glaucoma group is thin than the normal. That means they are having some kind of damage already. Understood? Hello.
Yes, it's clear. Thank you.
Yeah. So if you see that more clearly, the superinasal and the superior, 82 and 80 is not much significant. Similarly, superior is 81 and 77. If you see the p-value, it's p 0.04. That is not significant. But if you look at the inferior values, inferotemporal and the inferior one, the normal group had 80 micron thickness, whereas the pre-perimetric glaucoma had 71. So what it shows that the inferior happens more earlier in the pre-perimetric glaucoma group than the normal population. So whenever there is a ganglion cell complex which gets affected in glaucoma, it affects the inferior area more commonly than the superior. So if you look at, just 1 minute, I'm sharing my screen again. Yeah. So if you look at this picture, which is from the article itself, you see this temporal wedge. Can you see this?
Yes, yes.
Yeah. So that shows the significance, which is equal to this. You see, superiorly it is 79, inferiorly it is 71. So this difference between the superotemporal and the inferotemporal is the difference which is seen as this small wedge. This is seen even in normal people. There is a difference between superior and the inferior. But when it happens in actual glaucoma, you will see like this. Can you see this now?
Yes, yes, I can see that.
So this step defect is very prominent, and this step defect corresponds to your inferior thinning, which is shown as the yellow inferior, which is seen as the RNFL defect in the optic nerve head OCT. And also here you can see it as the broad RNFL defect. Can you see this black color broad RNFL defect? So
Yes.
this broad RNFL defect corresponds to the OCT here in the blue picture, corresponds to the same inferior thinning in the yellow line. And when it's shown in the GCC IPL complex, the macular ganglion cell complex, it is seen as this step deformity. But if you see the same patient's HVF, it's looking like almost normal, except for this one change, which if you are not very experienced, you might think that this is patient's learning curve and you will say, you know, everything is fine. Understood?
Yes, thank you.
Hello, Mahesh.
Yeah, now you can share your slides and you can continue again.
Hello, Mahesh. So what you have described, hello, Mahesh.
Yes, Mumbi. Yes, I can hear you. I can hear you. Your voice and my voice, I think, but I can hear you.
Yes, so what you have explained concerning the inferior thinness, is this
Yeah.
only being described, are you referring this only to this article, or generally that's what happens?
No, this it happens generally also. Even in this article, they showed a normal picture. So that's what I showed you the first image. When I showed you the first image, that was the normal picture. So even normal GC IPL complex, the superior is thicker than the inferior. So you will usually see a step defect.
Yes,
But
so the
that
follow
step defect becomes more pronounced when the glaucoma progresses, as I showed you in the another picture.
yes, so what is the explanation to this phenomenon?
As the glaucoma progresses and as your retinal nerve fiber layer gets damaged more and more, then the step defect will be seen, because GCIPL complex includes RNFL, ganglion cell layer, and the inner plexiform layer. So as much as your RNFL gets damaged, that the step deformity keeps on increasing.
Okay.
Okay, thank you, Dr. Mike.
Yeah, carry on.
I can go on.
Yes, please.
Okay.
I'm sorry, I'm interrupting in between, but I think that's
It's
how it
okay.
can be done.
It's okay. So for the sensitivity at fixed specificity, cutoff
I
values for
can't
the
see your slides. I think you have to share your slides.
oh, okay. You can see it. Can you see it? Okay. So table 14 is showing us the sensitivity at fixed specificity for the parameters. So at 90% specificity, we can see that the average cap average CD and the vertical average CD, the cap volume, as well as the inferior temporal superior nasal ganglion cell inner plexiform layer asymmetric index recorded the highest percentage of 52.2%, which was followed by vertical CD, as well as the inferior temporal and superior nasal ganglion cell inner plexiform layer up to the difference. Then at 90%, 95% specificity, the inferior temporal and superior nasal ganglion cell inner plexiform layer index recorded the highest sensitivity at 46.3%, which was followed by the vertical CD at 41.8%.
I think Bridget, you can put the that AUROC image, that area under the receiver operating curve image. If you have put it in your slide, it's there, I think.
Yes, it's
Yeah,
here.
yeah.
Yes.
So I'll just explain it this thing. So how you will interpret the ROC curve is, whichever is towards the left of the ROC curve has the best predicting value. So because superiorly, can you see one is mentioned at the top?
Yes.
Yeah. So whichever image is the, and if you see that sensitivity and specificity, they are at 90 degrees to each other, and there is a very faint line which is going through the center, that is at the 45-degree mark, which is dividing it into two half, right?
Yes.
Yes. So whichever curve is there towards the left hand side of you is better. That's the simplest way to understand the ROC curve, and it has got a good sensitivity test. Okay. So now if you see, all the curves are there towards your left hand side. So you need to see which is most closest to the number one value. That is your, the one which is shown with the red arrow,
Yes.
which is the inferotemporal GCIPL. And that is the same inferotemporal GCIPL value that I showed you as the step defect
Okay.
in the GCIPL. You understood that?
Yes.
Yeah. So earliest change that we can see in the pre-perimetric glaucoma is seen in that GCIPL complex, and even within the 6 sectors that we see in the GCIPL complex, it is the inferotemporal GCIPL complex which is more sensitive in picking up the defect. And then the second one which comes is your average RNFL. Yeah. So even before your RNFL changes happen, if you think there is some defect which is the damage that is happening, then you ask the patient to undergo OCT macular protocol with the GCIPL, and you look at the inferotemporal value, and the inferotemporal and the supratemporal, if there is any discrepancy and if there is a major difference and there is a step deformity is seen, then you can be pretty much sure that this patient is having a pre-perimetric glaucoma.
Thank you. Thank
Yeah.
you very much.
Right. Go ahead.
So I mentioned these results.
Yeah,
So
these
now,
tables are not needed. Yeah, you can go with the author's interpretation.
yes, now we'll go into the author's interpretation. As we know, the standard definition of glaucoma is based primarily on the optic nerve as well as the optic nerve fiber layer. So there's a bias that is favoring the optic nerve head, and the retinal nerve fiber layer would underestimate the diagnostic ability of macular parameters, despite that there's a glaucoma damage involves the macula. Then the ganglion have shown a better diagnostic ability than the retinal nerve fiber layer and also the optic nerve head parameters in myopic PPG group. Then also the diagnostic ability of ganglion cell inner plates from layer asymmetric measurements was comparable to that of the ganglion cell inner plates from layer thickness analysis for the PPG. So the present results are relevant to discriminate between the PPG and the normal eyes in clinical practice. That was the author's interpretation. So in conclusion, ganglion cell inner plates from layer asymmetric measurements have diagnostic ability comparable to the circumpapillary retinal nerve fiber layer, the ganglion cell inner plates from layer, as well as the optic nerve head analysis for PPG. Then the best macular ganglion cell asymmetric parameter was the inferotemporal and superior nasal asymmetric index. And this may serve as a new parameter for detecting early structural changes in pre-perimetric glaucoma. So now we'll go into critiquing our article, and we'll use the Marie to critique the article. So for the methods, the study design and the study period, as well as the location, was clearly stated. Then the sample size was given, though it was small. Then there was also an inclusion and exclusion criteria, which was stated. The consent and the ethical approval was also obtained. For assessment, we can say that this was a prospective study with a comparative study, which clearly defined the selection into normal and also the PPG category. Then for assessment, we can say that the study question was answered, and all the images were evaluated by 3 specialists, glaucoma specialists, which is a plus, and also the masking of results was mentioned. For the results, the data was well presented, though the sample size was small, and also there was a biasness that all the subjects were of Chinese ethnicity. And also, we can say that they really never mentioned how many eyes were analyzed, because earlier on they said that there were 67 eyes that were enrolled. Then they did the exclusion for the photographs, but they really never told us how many eyes were analyzed at the end of the program. So for interpretation, ganglion cell inner preform layer parameters have shown a better diagnostic ability in myopic PPG patients. Then ganglion macular ganglion cell asymmetry could be a new parameter to detect early structural changes in PPG. For extrapolation, we can say that the sample size was relatively small. There will be need to conduct a study with a bigger size. Then also the study subjects were all of Chinese ethnicity. So there might be need for there might be need for more studies tailored to our ethnicity before we can actually use this in our clinical practice. That's the end of my presentation. Thank you very much.
Right. Thank you, Bridget. Thank you. That was a very nice presentation. Do we have the other specialist? Is she there?
Hello, I've just joined.
Oh, just
Yes.
joined? Okay.
Yes, it's a very, I've seen the last part. It's a very nice.
Right.
And I like the fact that pre-perimetric glaucoma can be seen using the ganglion cell complex. Because when you have a myopic patient, it's very difficult to say, is it glaucoma when you're just looking at the optic nerve? So sometimes you end up over treating myopics who are not glaucomatous. So the macular ganglion cell becomes very important to differentiate this is in myopia or it's glaucoma or just myopia alone. It's very important parameter for that.
It's true. And any comments from your side?
I thought it's a very good presentation. It's very nice to have this kind of machine and to utilize it, because sometimes you don't know when people are going to develop glaucoma. So if you can catch them in pre-perimetric stage, to be very good, be able to save a lot of vision.
Fine. So, Bridget, I just wanted to tell a few things. Just 1 minute. I'm sharing my screen again. So, what happened study was just 1 minute. Sorry. So if you see the article itself, can you see the article which I'm sharing now? Hello, can you see my screen, the article page?
Yes, we can.
Yes, we can see.
Anybody can respond, please.
Yes, yes, we can see the screen.
Yes, we can see.
I can't hear the person, but
We
I think
can
there is
see
a
it.
response coming, or you can just type your. Hello, can you hear me?
Yes, we can hear, but
Yes, we
no.
can hear you.
Yeah. Sorry, I lost internet connection. That's why. Now, can you see this screen?
Mahesh, we are only seeing your screensaver so far. I think the internet is a little bit slower.
Hello?
We can see your screensaver only. Hello, Mahesh.
I think so. Yeah.
Yeah.
Can you see my screen?
Yes, we can
Yes.
see it now.
Article that we are discussing today, that is on screen.
Yes, Mahesh, we can see it.
Screensaver. Oh, okay. I think it's not the room for a better reception of internet. The screen now. Okay, fine. So what I was telling you is the examination 24-2 only. So what happens is if you do a 24-2 only, you will get something like this. And these points that are, away from each other does not fulfill the Anderson's criteria. And you will think that this is a normal visual field and you'll just send the patient back home. So you cannot label a patient as pre-perimetric glaucoma unless you have done a 10-2 image. Is that very clear? That point has to be the take-home message from this. You have to do a 10-2, and if 10-2 image is fine, then only you can say patient is fine.
Okay.
You see this image, the optic disc shows a nice RNFL defect. You can see this. My pointer is moving. Which is seen here in your RNFL analysis as this blue wedge defect, which is also seen in the inferior thinning shown as yellow color, and also seen in your OCT GC-IPL complex as your step deformity. Whereas your 24-2 just shows a central point involvement. And whenever this central point is involved, you must get a 10-2 image. Okay. So that was one thing which the authors could have done, not just do a 24-2 and tell that, you know, it's a pre-perimetric glaucoma. You have to do a 10-2. And finally, what my opinion is, OCT is just an added machine to help you make diagnosis. You will only send the patient for OCT if you have a doubt that there might be a change, right? So when will the doubt come? The doubt will only come if you do a proper examination, optic nerve head examination. So OCT is a new thing. It can have its advantages and disadvantages. It is only additional tool to help you, but the basic is always your clinical judgment and clinical evaluation
Mahesh,
of the
Mahesh,
optic disc is more
Mahesh.
important.
Yeah, sorry, we're having a lag. I think there's a problem with internet connection.
Is that fine?
Yeah, it's fine now. It was fluctuating. It looks like we have lost Mahesh. Bridget, are you there?
Yes, I am.
Yeah, Phyllis, I don't know. Phyllis, could you take over? I think your colleague. I think your colleague. We have lost your colleague.
Hello, the connection is quite bad. I can hardly hear people
Yeah,
talking.
it's everywhere. Apparently, even from here also, we're having a challenge, but we can hear you clear. You can go ahead.
Okay. Okay. So yeah, as Mahesh was saying, a 10-2 is very important because sometimes the defect is very close to fixation. So if you end up with a 24-2, no, you miss that. So always order both 24-2 and 10-2. Some machines are able to make a 10-2 from 24-2. So if you have that machine, it's very good. If not, then you have to order them separately. Yeah.
That's a very good point. That's what I was trying to tell. Because pre-perimetric glaucoma tends to be more closer to the fixation, and that you can miss it in the 24-2. So always ask for a 10-2. And what I was making another point is this OCT and all will help you to make your diagnosis, just to confirm your diagnosis. And
Yeah.
you will send your patient to OCT only if you have the doubt that there is something wrong. And to have that doubt, you should have a good examination skill. And finally, it is your eye that sees the optic nerve and the RNFL. And then if you see the defect, then send the patient for OCT. Otherwise, you cannot just send OCT for all the patient and, you know, depend on the machine to find defect.
Uh-huh.
Yeah, that's all.
Thank you.
Oh, okay, I'm not sure. To the moderators, perhaps we can allow some questions from the listeners.
Yes.
Yeah.
Anybody has any doubt, any part of the talk was not clear, can just ask doubt. Sure.
Anyone with a question? Dr. Mbulo?
Not a question as such, Dr. Mumbi.
Yes, Dr.
But,
Mtati.
is Mahesh able to share his contacts so that we can keep in touch?
Yeah, sure.
Thank you.
Okay, thank you. Okay. Any other questions and contributions? Dr. Chimozi Tembo, anything that you have been having challenges before? Dr. Chimozi Tembo? Is network lost? Am I audible?
Mumbai, I think everybody
We can
is
hear you. We can hear
almost
you.
in the evening mood. Yeah.
Okay, I see. Okay, yes. I thought my connection was lost.
No, nobody is responding. It's very much clear.
Okay, thank you. Yeah, so just one doubt a little bit further away from macular ganglion cell analysis. If you can just maybe show a slide on the retinal nerve fiber layer analysis. A few things I've been wondering what the relevance is. Maybe today I can get clarification. If you can just show either Bridget or Mahesh, the initial picture you showed, that was showing the first image earlier on when we just started. The front, the first analysis or review that you get on OCT retinal nerve fiber layer analysis.
I have this one. This is just the RNFL. I think Bridget.
Yeah, I think the one Bridget shared.
has that. Bridget can
Yes.
share it.
Bridget?
Bridget, can you share that?
Well, sorry, Dr. Mumbi, my computer has just gone off.
Okay.
It's a full.
Sorry.
Okay, unfortunately. Okay, what I was trying to ask is, you see there are those parameters.
Just give me a moment. I can download an image and share.
Okay.
Yeah. You go ahead, Mumbi. Just keep going
yes.
ahead. Yes.
Yes. So you get those parameters that appear. One of them that was being pointed at is vertical cup disc ratio. I know some of these parameters you can get them with your on examination. I was just wondering what the relevance of the volume that is given, the cup disc volume. When do I use it? And then I normally don't rely on the cup disc ratio from the OCT because I believe sometimes centration might be wrong. So I just wanted to do maybe to clarify on some of those parameters that are indicated, and when do you become when exactly do you use some of those parameters?
Is the image
Mahesh, I think there's a lag again with your internet.
now?
I think your internet is unstable again. There's a lag. Yes, I can see it.
Is my screen seeing Mumbai?
Yes, I'm assuming you are saying, is this the screen? Yes, it is. So those values, although not being seen clearly, that this same page. So what is the relevance of some of these ones, like the cup volume and the cup size? When are they applicable?
Yeah, you might be able to see now. Yes. So the box which says these values which are there in the top, average RNFL thickness, symmetry, and all that thing, right?
Yeah, Mahesh, I think most of the people are unable to see your screen. I think your internet again is still unstable. Oh, okay. We're asking the ones who are just joining, please kindly mute the
Mumbi, I
mics.
think your question was, Mumbi?
Yes, Mahesh.
Your question was that the cup volume and the cup disc ratio which is given by the machine, is it reliable or not?
Not really. My question was, what is the relevance of the cup volume? When do I apply it in my practice?
Cup volume does not make a difference because you might have a deep cup, but the cup may be normal. You might have a very shallow cup, still it may be normal. So cup volume does not make much difference.
Okay. I was trying to open the floor for questions. If there's no one with a burning question, I think we'll just allow the two moderators to give a closing remarks.
Hello?
Dr. Munga, please go ahead.
Yes. Thank you. So I just wanted to say that there's nothing very difficult about analyzing an OCT and the visual field. It's very easy. If you have questions, please always ask. We're here to answer your questions and help you through the analysis. And as we say, don't order OCT on everyone who's got what you might think as a big cup. It's not necessary. Look at the cup, analyze it. Is there anything off about this cup? Then you can order an OCT. And you should know what you're looking for in the OCT. Don't just order and don't know what to look for. So you should order and at least know what to expect or what to see there. To be relevant to order and just pack it up. It's not right. Yeah. Otherwise, thanks, Bridget. It was a very nice presentation. Well done.
Thank you.
Yeah, thank you, Bridget. And that was very true, Dr. Munga, what you said. And what I would like the registrars to, sometimes do is, if you have a doubt in a patient, ask for a fundus photograph and not for an OCT. And let that photograph be saved. And at the end of the day, you can talk to your consultant and discuss what is this cup and why is this normal and why is this abnormal. That will be much cheaper than sending the patient for a OCT RNFL, which will be costlier for the patient.
Yeah.
And thank you so much, Mumbi, for having me. And please send my regards to Mr. President, Dr. Kasongle.
Yeah. Thank you very much, Mahesh. I'm not sure whether you have shared your details already. As
I was
requested.
supposed to send my contact number +91948619.
Okay.
9148619938. Yeah, that's my WhatsApp number, which is just sent into the chat.
Okay, so we can keep the conversation. We hope. I know that side is late and you are going to sleep, but just aging.
It's pretty early for me to go to sleep. It's fine. But
Great,
we can have the discussion over mail or whatever. Yes.
Okay, yeah, so it's an opportunity. We can continue the discussion with Dr. Mahesh on the side for any clarifications. And we hope also, again, to include you, be part of our family for further discussions that you have in future. We appreciate for sparing your time and spending it with us. And I think it's time well spent on us. Thank you very much. And to everyone, we continue next week. With the presentation. I think the host this time will be Kitwe Teaching Hospital. So we're urging the people from Kitwe to prepare adequately. Thank you very much, the presenter for today, and also the Ndola team. I know it was teamwork. The Ndola team, a lot of people put in a lot of work. We encourage you and encourage other centers to continue working together as a team. If one person is presenting, it is not their presentation, but it's a presentation for the entire team. Thank you very much. Unless there's any one word that is burning before we eventually close the meeting.
Thank you.
Thank you, Dr. Mungu. Thank you, everyone.
Okay. Good night. Take care, people. Take care. Stay safe.
Thank you. Bye-bye.
Thank you.
Yeah.
Thank you. Bye.
Yeah, so just for everyone, you still find this presentation on our channel. Yeah, so and other presentations that you have done before. Thank you.